I'm going to talk about multimodal imaging based on subsource OCT in myopic vitreoretinal interface disorders. This is my financial disclosure. The main vitreoretinal interface disorders are vitumacular adhesion or traction, retinoschisis, macular hole that can be lamellar or full thickness, and epiretinal membranes. Several studies show that subsource OCT is superior to spectral domain OCT when imaging highly myopic eyes, especially in the presence of a posterior staphyloma, like in this case, or in this other case, with a concomitant macular hole retinal detachment and a double posterior staphyloma. In this case, we can see that the spectral domain OCT is not helpful to image the whole posterior staphyloma in comparison with the subsource OCT. Vitumacular adhesions or tractions can be very nicely seen with a subsource OCT, like in this case, or this more advanced case, or this case with a foveal detachment that can evolve into a full thickness macular hole. We know that retinoschisis is the hallmark of myopic tractional maculopathy. We know that this tractional component is one of the leading causes of visual impairment in myopic patients. We can have retinoschisis involving the inner retinal layers, or both the inner and the outer retinal layers. In some cases, can be juxtapapillary, or could have a concomitant disorder like a CMV in this case. In this example, we see retinoschisis in a patient with a choroidal excavation. Multimodal imaging can be helpful in these patients. In this case of inner foveoschisis, we can see the OCTA, we can see the vascularization of the retina, and with the EMPHASE imaging, we can see very nicely the distribution of the cyst in the superficial and especially in the deep plexus. In this other case, with the outer foveoschisis, we can see the cyst in the EMPHASE imaging, and the OCT angiography is relatively normal in this patient. In this more advanced case, with a patient with retinoschisis and choroidal excavation and atrophy, the patchy of atrophy can be seen with the OCTA. In this patient with both inner and outer retinoschisis, the OCTA is not very, the quality is not very high due to the presence of the staphyloma, but we can see the vascularization of the retina. Macular hole can be lamellar full thickness. Lamellar macular holes are relatively common in myopic patients. In some cases can be mild, moderate, or severe, or in this case with a huge lamellar macular hole. Lamellar macular hole can be seen with the EMPHASE, we see the distribution of the cyst, or with the OCTA, we can see the vascularization of the retina. In this case, with the EMPHASE, we can see the edge of the posterior staphyloma. In some cases, the retinoschisis can evolve into a macular hole, and it can be small or larger, like in this case. Some cases can evolve into macular hole retinal detachment. In this case, we can see the pre-op imaging and the post-op imaging. In a full thickness macular hole in a myopic patient, we can see the 3D image, the vascularization of the retina with the OCTA, the cyst with the EMPHASE imaging, and the post-op recovery. And we can see the recovery of the vascularization of the retina. And in EMPHASE imaging, we can see the dimples typically seen when we peel the ILM. And in epiretinal membranes, this is a pre-op case, the distortion of the vessels, as you can see with the OCTA, especially in the superficial and the plexuses, the EMPHASE imaging, and the recovery after the surgery, and the restoration of the different plexuses of the retina with the OCTA and the EMPHASE. To sum up, we can see that subsource OCT is clearly better than a spectral domain OCT for the imaging of highly myopic eyes with vitreoretinal interface disorders. EMPHASE imaging is helpful to assess the distribution of cystic lesions in retinoschisis. OCTA is helpful to assess the potential damage over the retinal vessels induced by traction, and OCTA is helpful for the assessment of the post-op recovery. Thank you very much for your attention.